Welcome everyone to this morning's webinar on fostering MSD prevention, creating a safe and positive care experience working with hospitalized bariatric patients. I'm Catherine Brookman, Associate Director, Knowledge Transfer and Exchange, and on behalf of Dr. Jack Callahan, Director of the Center of Research Expertise for the Prevention of Musculoskeletal Disorders, or CRE-MSD as we are more commonly known, we would like to thank you for joining us for this free webinar. We'd also like to thank Public Services Health and Safety Association for partnering with us today, and a special recognition to Francis Zeiselman, who sourced today's speakers. We're grateful to the Ministry of Labor for our funding, which supports the delivery of these webinars, and to our presenters who provide their expertise. For those of you who haven't been on a CRE-MSD webinar before, the format of the webinar is as follows. The presenters will provide a presentation, and that will leave hopefully 10 to 15 minutes for questions. We ask that you type your questions into the chat box, and we will relay these questions to our presenters. Should you have a pressing question that cannot wait until the end of the presentation, please type it into the chat box. If in fact something is affecting your technology, we'll try and troubleshoot with you. Otherwise, the questions will be addressed after the presentation. And if we have too many questions for the time allotted, I will look at the most common themes and pick those out. The presentation will be recorded, and we will be providing you with a copy of the recording and the slide deck from the presenters shortly after the presentation. We will also be giving you an evaluation, which we really encourage you to fill out because that helps us plan for future webinars. This webinar was widely requested for the past 2 years, so we're really excited to have the opportunity to bring this webinar to you. It's my pleasure to introduce to you our two speakers. Mary Forhan is the Assistant Professor from the Department of Occupational Therapy, the Faculty of Medicine, the University of Alberta. She's a postdoctoral research fellow with the University Health Network in Toronto at the Toronto Rehab Institute. She has practiced as an occupational therapist and educator in the areas of obesity, mental health, and chronic disease management for over 20 years. She's worked in hospital and private practice settings, as well as educational and research institutions. She's an active member of the Canadian Obesity Network and joined the University of Alberta in 2013. She is leading a program of research focused on improving the care and rehabilitation outcomes of patients with obesity. And her co-presenter, Kathy Dmytruk, is Senior Advisor of Diabetes, Obesity, and Nutrition Strategic Clinical Network at Alberta Health Services. She's been involved in healthcare planning since 2005 and has extensive experience in project management and strategic planning. She's a registered dietitian and a certified diabetes educator. We have a huge audience today from a broad range of healthcare sectors, including the community, hospital, and long-term care. We have academic institutions on the line, Health and Safety Association, and ergonomists. We have a widespread audience from across Ontario as well as Canada, including PEI, Newfoundland, Saskatchewan, Nova Scotia, Manitoba, Alberta, New Brunswick. We also have some people from the US, from Ohio and Washington joining us. And I see that we have somebody who is in our Niagara casino today and has taken time out to call into this webinar. So all of that is very exciting. So without further ado, I'd like to introduce Mary and Kathy to take you through this presentation.
Great. Thank you so much, Catherine. I'm going to assume, unless I get a sign otherwise, that everybody can hear us okay. So this is a great opportunity. Thank you so much for all joining in today. What we're hoping to do today is just provide a really good overview of some of the things that we've been doing research-wise and trying to implement some of our research findings into the clinical setting. And we're hoping that this is just the first of many conversations to come on this topic. So why we started this was really, it's no surprise to anybody on the line, but healthcare professionals and administrators are really concerned about the risk of caring for patients with bariatric care needs. And I think from a healthcare perspective, a lot of us are just not well prepared as we move into the profession on how to safely work with patients to meet their needs. When we use the term bariatric care needs, we're really talking about patients who have a weight of 250 pounds or 133 kilograms, 113 kilograms, pardon me. I'm a bit old school still. And the reason we start so low with that is just that most chairs in waiting rooms or stools in clinic areas actually have a weight capacity of 250 pounds. So that's why we started with that. And we'll show you an algorithm that we've created as we move into the presentation. So we really want to start to have conversations about practices in clinical settings that reduce the risk for musculoskeletal disorders in healthcare professionals, but also the safety of patients that we're working with. So there we go. So the next thing we're going to talk about here is the Bariatric Friendly Care Hospital Project. And the purpose of this project, it's a collaboration with the University of Alberta Faculty of Rehabilitation Medicine and with the Alberta Health Services and the Diabetes, Obesity and Nutrition Strategic Clinical Network, which is part of Alberta Health Services. I am from Ontario about 5 years ago, and one of the things that's unique about Alberta Health Services is they've started these strategic clinical networks which really help bridge research and implementing that into clinical practice. So it's just been a wonderful opportunity for us to realize this project here in Alberta. So what we're hoping to do with, well, what we are doing with this project is developing standards for bariatric friendly care in the hospital environment within Alberta Health Services facilities. Standards will support healthcare providers to become more knowledgeable about obesity, to work effectively and compassionately with patients with obesity, and to develop competencies in the area of safe patient handling and safe clinical care. So this is our team. We are made up of industry partners who do industrial design and architecture and also service design. So we have a lot of sort of designers as part of our team. We have rehab researchers and clinicians as part of our team. We have individuals living with obesity who have had in-hospital experiences so that they can contribute. And these are not just token people at the table. These are people who are research partners and patient advisors on our teams from the very beginning. And then we also work very closely with hospital administration and staff. It's really important that we have the senior management buy-in. So again, they've been part of our group from the very beginning. In terms of the rationale, some of the surveys that we've done to date in Alberta, and when I've done some cursory looks at some data across Canada, it's not really that different from province to province. So at any given time, we know that 35% of hospitalized patients live with obesity. So that's a body mass index of 30 kilograms per meter square or more. And they are at increased risk for injury and complications associated with their size. I don't know why I forgot to take that slide out. So this is just a different version with a different picture of our slide, just in case you're interested to see what our South Campus looks like. Sorry about that. What we did here was we, as part of our research group, we started a project about 3 years ago where we gathered key stakeholders from across Canada. So we had hospital frontline staff and administrators from most provinces across Canada come and share their concerns and issues related with caring for patients with obesity in the hospital. And the results of this group were that, so we had 18 healthcare professionals from across Canada met. We asked them to review some results of the scoping review that we had done that tried to highlight from the literature what some of the key issues were and key concerns. We did have a report. We haven't published this yet. We are planning on publishing it as sort of a whole research report. And what we found were there was issues around patient safety, access to equipment, not really having any idea about what obesity was in the context of a chronic disease. And so there were key areas that we needed to look at, which was this continuum of care, the design and availability of equipment, education for healthcare professionals, and looking at factors within the system that would help promote patient safety throughout their healthcare journey from the time they were admitted until the time they actually are getting ready to leave. Then we also had met with patients living with obesity who had hospital experience. We decided to meet with this group separately after the healthcare professional group. And that was just at the very beginning where we weren't sure if people would be comfortable talking openly and candidly if we mixed the groups. So we had 6 patients living with obesity from across Alberta come to Edmonton for a day. We asked them to review the results of our report, actually, from what healthcare providers were saying about their concerns working with patients with bariatric care needs. And what was really interesting is that the patients endorsed everything that the healthcare providers were saying and then added a little bit more detail. So what we did was we, again, have another report that we will make publicly available. This was just for our summary today, that they identified issues around making sure that their needs were met in terms of safety and access to equipment, but also safe and respectful care throughout every touch point in the healthcare system, from emergency right through to discharge planning. They also reinforce the need to have access to equipment that meets their needs and is comfortable, but also looks good. They also recognize that healthcare professionals, for the most part, are trying to do the best that they can, but they just don't have the training and education and aren't comfortable working with patients with bariatric care needs. They also recognize that leadership is really needed to promote awareness about bariatric issues, and the issue of respect came up again and again. Okay, so some key messages that came up from our studies were that staff and patients just don't feel safe. Staff do not feel adequately prepared. Weight bias and stigma exists in every single healthcare situation we were talking about. And this isn't unique to Alberta. I've done surveys across Canada, and it doesn't matter what discipline I'm looking at, whether it's physicians, occupational therapists, physical therapists, dietitians, porters, frontline staff, clerks, nurses. We all have bias, and sometimes it really comes out in a really negative and impactful way in the care that we provide. Programs across the hospitals and units are just not prepared. There's this culture of reacting rather than anticipating, which I'm really happy to see is starting to shift a little bit. Wait times and delays at all points in the system are causing delays in care and put patients and staff at risk. Post-surgical infection risk is very high, primarily because we don't know how to manage patients with obesity in the best way. And one of the things that's happening quite a bit is that patients are sitting in bed longer than they need to compared to their counterparts who don't have obesity. What was really highlighted strongly in our research so far is that so many times when we went to the patient record, missing values for height and weight were there. So oftentimes we're guessing at what the weight of the patient is, and we may be putting patients at unnecessary risk by not having this information available. Waist circumference is rarely reported, and sometimes that's really important for us to know when we're using things like transfer belts, or we're looking at the widths and depths of wheelchairs and other seating issues. And there's no way to connect the patient or staff injury with BMI. In Alberta, we were not able to look at injury rates of staff and see if it was related to caring for a patient with bariatric care needs. So we need to improve that reporting strategy. And it's not in a way to start blaming patients with obesity. It's so that we can have leverage to provide safe care environments for patients and the people that work with them. So what patients have said. In general, we've surveyed patients across Alberta, and just little things that have come up that impact their care is that gowns are too small. There's a lack of appropriate equipment, whether it be mobility equipment, intubation equipment, speculums for pelvic exams, blood pressure cuffs. These are all the kinds of things that we've heard are missing, and patients notice this. They experience bias and blame and shame throughout the system, and they overall feel that they have a loss of dignity when they're brought into hospital. So the Bariatric Friendly Initiative project has kicked into gear, and throughout research completed by our group, we've identified key interventions to improve the quality of care for patients with obesity and to develop provider competencies to deliver safe and effective care. These interventions emphasize the need to change attitudes, both through education, but also creating safer physical environments for both the patient and care providers. So the Bariatric Friendly Hospital Initiative is taking research and moving it right into practice. So what we're going to share with you today is some information from some guidelines. We're not calling these best practice guidelines, because there really isn't a lot of evidence out there to say that most of what we want to do has evidence. But what we do know is it makes good clinical sense, and the evidence will come once we start evaluating these implementations. So we're proposing guidelines for the care of hospitalized patients with bariatric care needs, and we expect that these will be ready for sharing by the end of the summer. And these are developed by Alberta Health Services, the University of Alberta, and also the Canadian Obesity Network, which as of this week has been renamed Obesity Canada. Same organization, just a different name. So in terms of the guidelines, I'm going to go over just the table of contents, and then Kathy's going to go into some more detail about specific recommendations. So just to give you an idea of what's coming down, and I also just want to state for those of you on the line, there are recommendations and strategies that are published and readily available. But what we found was nothing was organized into a complete and comprehensive guideline that was provided in such a way that independent hospitals or various hospitals could adapt them to suit their context. So our goal was to take what's out there, put it into a usable, easy, and comprehensive format. So we're not suggesting that we've developed a lot of new and novel care ways, but what we've done is taken and evaluated what's out there and tried to pull it all into one place. So some of this will not be new to you, but it's all in one place now. So one of the key topics is identification of patients with bariatric care needs. So we're going to share with you a decision-making algorithm that we've developed and the use of a bariatric risk assessment. The other chapter is providing care for patients with bariatric care needs there's some common comorbid conditions. So we've got clinical recommendations for patients with obesity who also have issues with the cardiovascular system, risks of thrombosis and pulmonary embolism, respiratory system and airway management, urinary incontinence, gastrointestinal system. We also have a section on personal care that includes tips and strategies for hygiene and skin and wound care. We have a way of mapping the patient's in-hospital journey and show the transitions between the wards, the units, and the programs. And any hospital can replicate this map that we're going to show you. We also talk about discharge planning well in advance of when the patient's getting ready to go. That's where we find a lot of patients end up sitting in alternative level of care. We also have a section on equipment needs and inventory, reducing patient risk of patient and staff injury. So this is a section that a lot of you on this call will be interested in around patient lift and transfers, mobility assessments, what happens when a patient falls at home or in an institutional setting. We have strategies on managing that. We have a section on education and training focused on weight bias and sensitivity and using person-first language. You'll hear Kathy and I talk about patients living with obesity or patients with bariatric care needs. And we really encourage that language as it helps reduce stigma and bias, and it also puts more value and respect on the patient. So we don't call patients bariatric patients or obese patients. We also have an image bank that is readily available through the Canadian Obesity Network and most recently through Alberta Health Services. We talk about room design and space design. And then the most important part for me as a researcher is this monitoring and evaluation. So we want to take a look at the impact on these interventions on in-hospital length of stay. We're quite convinced that with good care, we can reduce in-hospital length of stay. We can improve the patient experience. We can track incidents associated with caring for patients with bariatric care needs. So in terms of outcomes, I'm going to pass this over to Kathy, and here's Kathy.
Okay, thanks everybody for joining today. So again, just picking up where Mary left off, we're really making sure this bariatric hospital friendly initiative aligns with our core foundational strategies within AHS, being the patient first strategy, our people strategy, information management technology, and our clinical health and research section. So again, we're really focusing on improved patient safety, as Mary has discussed, with improving access to equipment, improving professional competency, and again, that will improve staff safety. The patient experience is very big. We know, as Mary talked about, weight bias and stigma is very prevalent in our hospital environment. So we really want to focus in on making sure that staff have some weight sensitivity training and understand that this is very important to treat all patients with respect and dignity. And we also want to look at improving transitions in care, as we talked about. So we know there's a lot of missed opportunities where they can communicate bariatric care needs of the patient and be more proactive in preparing to receive patients between departments. As right now we know they're very reactive, which further adds to the stigma the patients experience. So next slide. We have identified Medicine Hat, which is a hospital in the southern part of Alberta. It's a 200-bed hospital. They have agreed to be our demonstration pilot site to implement these 7 standards that we've come up to create a bariatric-friendly hospital. After we have implemented in the fall, oh, sorry, I see the note there. Sorry, I'll just try to speak a little louder. And we've done our comprehensive evaluation and measurement. We then will write a business case to scale and spread this across Alberta and modify the guidelines and the standards based on the feedback we get from this pilot site. And then it'll be available for anybody to access. So we did a survey of all the staff in the hospital. So we included everybody, frontline people, housekeeping, facilities management, and just to get an idea of where they're at with access to equipment, etc. And some of the comments that came out of that survey was they just have no training in bariatric care, they lack equipment, and when even if equipment is available, there's no process to share equipment between units. You're not sure how to use the bariatric specific equipment. And they just feel overall that people who are overweight get less effective care. So after sort of coinciding with the survey, we struck a steering committee, and again we had broad representation from all areas of the hospital: capital planning folks, facilities, diagnostic imaging lab services. So really got a big cross-section of folks that work in the hospital setting to help steer our direction in developing these standards and guidelines. So then we struck 4 working groups, again, based on Mary's research to move her findings into practice. We focused around 4 areas. Professional competency, so again, making sure the staff have weight sensitivity training, and our goal is to improve attitudes and behaviors towards people living with obesity. And then we focused on patient and provider safety. So that group looked at the inventory of equipment currently in the hospital, and then we did an analysis of where the gaps are and, you know, how many lifts they should have according to how many patients are in the hospital with obesity, etc. And then transitions, I'll talk a little bit more about in a minute. So again, making sure there's good handoffs between departments within the hospital so that the departments receiving the patient can be more proactive and prepared. And then evaluation and monitoring. Okay, sorry, I'm still not talking loud enough. Okay, sorry about that. So the next slide is a patient journey map. So we interviewed, again, all departments within the Medicine Hat Hospital to look at where they felt that things were working well and where things weren't working well. So the pink is actually the areas that are working well, and the black is where there's gaps and room for improvement. So just to give you some examples, you know, we interviewed EMS, and they talked a lot about, you know, not being able to get the patient into the helicopter or the airplane, things like that. And then a lot of people talked about the handoffs between departments and how patient would be taken down to diagnostic imaging for a CT scan. And then once they get there, the CT scan tech says they're too heavy for the equipment. So again, there's lots we can do to improve process, to improve communication, and again, make sure that the staff are proactive and prepared, have all the right equipment that they need, and that they are ready to receive the patients. So looking at injury rates, we've got the disabling injury rates across AHS, and Medicine Hat actually wasn't doing very good back in 2015-16. So they decided with the new bariatric videos that we'll tell you about in a minute, that Mary's group was involved in developing on safe lifting, handling, and transferring of patients. They implemented to have a champion on each unit take this additional training in caring for people with living with obesity, and ensuring that they knew how to use the equipment properly, and that they were on the unit at all times. There would be a champion for just-in-time support on the units in the hospital to help the bedside nurses and rehab staff safely move the patient. And they did drop the rates and have further dropped the rates to date. Well, so they went from 31 2 years ago to now 21 incidences of disabling injuries to the staff. So they are improving, but again, we're hoping with more awareness, more access to equipment, and this training using the bariatric videos that we can reduce this rate further. We also brought members of the working group to Edmonton, where we have a bariatric specialty care suite and a smart condo. And this was a 1.5 day training session where we learned about patient first language, weight bias. We have an actual hospital unit set up so we could, we had patients come where we could actually practice using the lifts and safe handling techniques. So we had an OT and a PT training the staff on proper use of equipment. And we also have, they have bariatric suits, which we were able to wear and experience living the life in a larger body and doing activities to daily living, which was very impactful exercise for many of us. So that was a great day and really helped the working group understand what we were trying to achieve with this project and be very motivated to go back to Medicine Hat and make changes. So the 7 standards that we came up with, again, as we've talked about, is access to equipment, knowing how to use the equipment, access to supplies like longer needles and blood pressure cuffs. So making sure that all the equipment for safe patient handling, but the clinical equipment is all readily available in patient care areas. And we really, again, want to focus on eliminating weight bias because we feel that frontline staff will be more motivated to access equipment and use it properly if we address bias and that they understand obesity and the complexity of it. And then we're also talking about personal care, as Mary talked about in the guidelines, and really making sure that body weight is recorded so that we can have a flag when a patient comes into the hospital setting, and that we can have the algorithm then triggered so that the staff can be prepared and proactive to organize equipment, etc., for that patient. And I'll just hand it back to Mary for some specifics about our standards.
Great. And I understand that some people are having trouble hearing. Sorry, Kathy and I are actually fighting colds right now, so we'll do our best to project as loud as possible. So the key standard and recommendation one that we have is that patients with bariatric care needs, excuse me, will have interactions with all staff, administrators, and physicians that establishes a foundation of trust, collaboration, and is free from weight bias. So this is a statement that is universal, can be applied to any healthcare setting. We happen to be talking about an acute care hospital. Our recommendation is that all staff, administrators, and physicians will complete weight bias training. And we have actually set up online modules that there are readily available online modules, but we wanted to make sure that it was specific to the culture and institutional needs that we had in Medicine Hat Hospital and in AHS in general. So this is Kathy in the lab coat, in case you're wondering what Kathy looks like. And what we've developed is some weight sensitivity training. So we use bariatric simulation suits in a clinical environment where we actually go through, as Kathy said, activities of daily living to try to raise awareness with clinicians about what it is we're asking patients to do in terms of mobility, even things like giving urine samples or doing toileting tasks, those kinds of things. It just raises awareness about some of the challenges and opportunities for improved clinical care. We also asked staff in a survey what kind of weight bias training they thought would be important. What we did find out is that 95% of the 600 people that responded to the survey said that weight bias is an issue and that training is essential. And most of them said that an online module for 20 to 25 minutes as part of their annual sort of continuing professional education was important. And then some said for those that want extra training and to be champions in their specific programs, that we could have some face-to-face sessions. And so some of our individuals living with obesity on our research team and training team will actually come and do in-house talks that has really had a really significant impact. The other standard that we have is every patient presenting to or admitted to the hospital will have their body weight and height recorded in a standard location in the medical record. This sounds so obvious, but as I said before, it's just not happening. And now with the emergence of electronic medical records and the use of Epic or Connect Care, or I'm not sure what it's called across Canada, but we are actually encouraging people to make sure that this is a forced field in any electronic record so that it is readily available and that we can see this quite readily. In terms of communication and recording, we're working with designers and administrators to include body weight and height as a forced entry, as I said, into the electronic record. And the reason that we're saying this is not because we want to highlight any patient with a higher body weight, but it's really for patient safety, not for making assumptions about their function or their ability. We want to educate about the importance of this information for staff safety, patient safety, human resource and equipment allocations, and research that will improve quality care. We are not saying that everybody who has a body weight of 250 pounds or more needs extra care, but the algorithm we're going to show you actually works through a process to identify those that may. So the key standard and recommendation number 3 is that the appropriate size equipment will be available for use by patients and staff. Again, this sounds like a really easy thing to do, but we know, and I'm sure those of you on the line recognize that this just isn't always possible. So what we want to do is recommend that bariatric equipment is readily available for use by patients with bariatric care needs when they present at hospital, not 3 days later after rentals are arranged and equipment is located. And we've got some novel strategies that we're trying to practice with in Alberta, such as GPS tracking systems and sign-in sheets and pooled equipment rooms so that equipment is shared across units, which again we're finding is more challenging than easier to do, but we've got some strategies to do that. So again, here are some things that we're working with. We actually have a unique opportunity to work with the Alberta AIDS for Daily Living program, or the Assistive Devices program if you're in Ontario, to look at how we can make equipment readily available for patients in their home environment as well. So our fourth recommendation is that all necessary staff will be knowledgeable on safe patient handling methods for patients with bariatric care needs. So all necessary staff will be required to complete the It's Your Move Safe Patient Handling program. That just happens to be the brand name of the occupational health and safety program that is run through Alberta. And what we've done is we have created 6 training videos to go along with that that are specific to bariatric lifts and transfers. And that includes things like bed to wheelchair transfers using mechanical lifts, walking slings for those who are in rehabilitation programs, how to manage limbs and lift limbs using mechanical devices so that we can provide good patient care and hygiene. We also have a paniculus lift and a training session so that we can know how to manage that abdominal paniculus that can get in the way of some patient care. And also as risk for skin and wound issues. We also have what happens if a patient falls in the hospital and how to safely get them up from the floor. So here's some just links, and we will provide this to the resource that will be shared with everybody who's attending today's session. These are links to the training videos that were done in collaboration with the Occupational Health and Safety Leads at Alberta Health Services, with the Canadian Obesity Network, and with the University of Alberta. So this is just a sample of some stuff. We do hope to have some more stuff readily available for your use. All of this has been vetted through our occupational health and safety programs and approved. So our last standard that we're going to share with you today is around communication of bariatric care needs. They're clear and efficient to promote a seamless transfer of patients throughout the hospital and also for discharge planning. And we're talking about elective admissions to the hospital, but also unexpected admissions through the emergency department. The recommendation here is that the identification of patients with bariatric care needs will be identified at the time of admission and be communicated at each transition point in the patient's journey throughout the hospital, including discharge planning. And this also is in preparation if they need to go to diagnostic imaging or to surgery or wherever they may be going while they're in hospital. And this is the algorithm. We don't expect that it's crystal clear on the slide, but I think we'll share the draft of this. Keep in mind it's something that we're working on and testing. And what this does is it flags that as soon as a patient comes in, we want their height and weight to be obtained. We're okay with reported height, but we want the weight taken, whether it's done on the stretcher, on a scale where possible, or in a bed with a scale. We want to make sure that the weight is captured. And if the weight is over 250 pounds or 113 kilograms, we then go into asking about, does the patient's height and body shape warrant considerations for bariatric needs? So do they have a paniculus? Do they carry their weight more in their abdominal area that might impact the size or width of a chair or a commode that they need? We also then want to look at their mobility. Do they have mobility equipment needs? And if so, making sure that they meet the weight requirement of the patient. Does the patient need more assistance for lifts and transfers? And if so, as we move up the needs section, we want to see if this person really does need a full bariatric care suite with all the bells and whistles. What we're finding in our research so far is that really a very small proportion of patients need the full care suite, but a number of patients need bits and pieces of things that might just be a rollator walker that meets their size and weight needs, or perhaps making sure that the toilet in their room has the weight capacity to support them, and if not, is a commode chair available that it will meet their needs. So sometimes it's very minor adjustments that need to be considered right up to full care. So the hospital administrators were quite relieved when we started looking at this algorithm, because they realized we're not asking for bariatric care suites, 5 or 6 of them throughout every unit. What we're actually finding is that if each program has access to at least one full suite, that's probably more than sufficient to meet all the demands in the smaller community hospital that we were looking at. And what this is an algorithm that we have adapted. Mary Lou Muir out of Manitoba had done some really wonderful research prior to her untimely passing, and she contributed a great deal, along with Gail Archer-Hess from Manitoba. We've put up here a discharge process to help with discharge planning well in advance of a patient getting ready to leave, and walks through some of the considerations and how to communicate those needs to home care or a long-term care facility, or perhaps a more intensive rehab facility that a patient may be transferred to. So we'll share this as well. It's readily available. As we said, we don't necessarily develop new things, but we just wanted to make sure everybody was aware of them and pulling them into one location. This is also something else that came out of Tampa, Florida. This is a bariatric risk assessment checklist that really helps programs do some inventory and check to see, is there areas of treatment and care conducive to providing safe and effective care for patients with bariatric care needs. So this actual type of checklist was what we used when we did an inventory of the Medicine Hat Hospital to identify every single room and place of care, to identify where there might be some barriers or concerns and room for improvement. So as I said, we've created some online education. We've created online education in the forms of what is obesity and why should we really care about it. We also have an education video on weight bias and sensitivity training. And then we also have our lifts and transfers and patient safety videos. Each video or each section is no more than 20 to 25 minutes, and people can come back as often as they want and review things as many times as need be. So where do we go from here? I'm just looking at Kathy because Kathy's suppressing a cough, and I'm going to keep going. Sorry about that. Kathy and I were going to share, but Kathy's just not feeling well this morning. So we recently did what we're going to do from here. We're actually going to be doing some implementation, and the Diabetes, Obesity, and Nutrition Strategic Clinical Network that Kathy works with is very, very involved in working with senior leadership at the Medicine Hat Hospital to implement some of the recommendations and strategies. We're starting with focusing on equipment and weight bias and sensitivity, and also on safe patient handling. And what we do is we have a very strong evaluation plan to measure levels of injury and incidence and satisfaction with patient care and staff confidence in their ability to manage care. And we're going to implement this and follow this over the next 3, 6 months, and 1 year. And as we learn and as we improve, we're actually going to be scaling this and spreading this throughout every hospital at Alberta Health Services, which is all across Alberta. We also have interest from many hospitals, some of whom I think are online today, in Ontario and Newfoundland, specifically, that are really interested in taking some of our guidelines, adapting them for their own use, but involving and sharing their reports back with us so that we can do large-scale evaluation. This is just a picture of the bariatric care suite, where we do all of our training. So it's a simulated bariatric care suite where we can test out various equipment. We can do lifts and training. We can try out configurations of rooms. We do product testing here as well. What you see lying on the floor there is a bariatric mannequin. We call him Barry. Barry is 450 pounds, and we use this to do training for lifts and transfers if a patient falls. We also do training with firefighters and EMS, first responders, in case they need to do things like evacuations in hospital or home or long-term care settings. And I believe we are just coming to the end here. We did this really fast. We wanted to give lots of times for questions and answers. So we're going to open it up now for some discussions and suggestions.
Thank you so much. Excellent presentation. You've certainly highlighted all the care considerations to support safety of both the staff and the client. And I think people really will appreciate the video resources that you've sent. And I'll follow up with you on a couple of things. The video on the sensitivity training I think might be of interest to some organizations, and also your evaluation plan. So I'm going to jump into some of the questions that are rolling in. Early on, a question from one of our hospitals. So your algorithm is strictly based on the weight of the patient is the question. And what about a patient that doesn't reach this weight threshold but has limitations in mobility due to their size?
Yeah, I think that's a great question. I think that question may have come before we showed the algorithm. So I'm going to just flip back to the algorithm. And again, I'm sorry you can't see the level of detail, but we will share this. So I think as soon as you have, we wanted to start with the weight. And the reason we started with the weight had nothing to do with function of the client or the patient. It was really about the maximum weight capacity of some of the standard equipment, especially seating, stools and chairs in the hospital environment. And when we did a scan, this seemed to be where concerns started to rise. But that doesn't mean you may have a patient at a lower weight that is perhaps shorter and maybe broader or wider and doesn't fit into a standard, let's say, waiting room or bedside chair that has arms. So the weight capacity might not be the issue, but the actual fit and size. So people are going to need to use their clinical judgment. We needed to have the weight to start with this algorithm around bariatric care needs. And then we do go through the mobility assessment, which many places have standard mobility assessments done either by OT, PT, sometimes in some places it may be nursing that's screening patients. So what we're really interested in is getting feedback on people that use this algorithm on what are some of the key things we need to make sure that we include in here. We wanted to keep it as simple as possible, but in doing so, we may miss some key points as well. So mobility is certainly an issue to consider, and also the function of the patient and how much assistance do they need, and perhaps what their risk is too, in terms of skin infection, wound care, respiratory distress. Those are all things that are going to need to be considered as well.
Great, thank you for that answer. There has been a question around funding for the purchase of bariatric equipment. Was that available to you at the start of the project at Medicine Hat?
No, actually, it wasn't, and that's a problem across the country, I'm sure. But what we're doing is, we didn't mention this, but doing an economic analysis as part of this study has been really important. We are just about to, well, actually tomorrow morning, members of our team are actually pitching a proposal where we're asking for a fairly significant amount of money, just short of $1 million actually, to fully realize all of this study, but also moving it into the home care environment. But what we did is we did a brief economic analysis to show proof of concept. And what we showed that if we can reduce the injury rate by one staff person, so if we can keep one person from going on disability from the hospital, it actually pays for a significant amount of equipment. So this equipment, we know from the economic analysis, actually could save money by reducing the loss of staff time and injury. And also too, promoting a quicker discharge and move through the system so that patients with bariatric care needs who could be cared in the home environment or a rehab setting are actually not sitting and blocking. I know blocking beds is not an appropriate term, but that they're not sitting and waiting for care, listed at alternative level of care, and not receiving any really expensive acute care services. So that's where the money, the reinvestment we're suggesting, is that these things are actually going to pay for themselves in a very short period of
And I
time.
think that you're
We're
also
also
training people from other disciplines that you mentioned. So paramedics are coming in, getting their training, firefighters, community people. So you're not duplicating, training centers, which is also a good return on investment.
Yeah, good
Did
point.
you
Yeah.
did you have a measure of the safety culture before you started this project? And is that why
Just
maybe
saw
you
that.
introduced the video on sensitivity training?
Yeah, I wouldn't classify it as a safety culture survey, but we did measure weight bias and sensitivity using a standardized weight bias attitudes and beliefs survey that has come out of the Yale Red Center in the U.S. And this is a survey that actually is really effective. We've used this survey with almost over 1,000 people across Alberta at this point. And what we were able to do was to take the results of the survey to show what the attitudes towards patients with obesity were across the healthcare center, and also what the beliefs about obesity were. And what that allowed us to do was that we recognized that there was a lot of myths and misconceptions about what the ability and what the character of people living with obesity actually is. And that's what the weight bias and training videos are targeting. We also realize that a lot of people don't really know what obesity is. And there's a lot of assumptions that it's just simply a matter of eating too much and not moving enough, and that it's self-inflicted. So once we started doing education about obesity as a chronic health condition and showing the complexity of the causes and consequences of obesity, we found that the weight bias and sensitivity improved and weight bias went down. So it wasn't a safety cultural survey per se, but it certainly does have implications for that.
Thank you very much for that. And here's a very practical question. Where did you purchase the bariatric suit from?
I can share that with you. It's so the bariatric simulation suit. I do hear people call them fat suits. I'm not seeing this here, which is wonderful. We call them bariatric simulation suits. They come out of Denmark, and I'm so happy to say it's an occupational therapist in Denmark named Maylene Adronovich. I always say her name wrong. She developed the suits to use in training. She does a lot of training around lifts and transfers and managing patients with bariatric care needs. So they are available from a company called Kobe Rehab. It's COBI. They used to be called Rehab Double XL. I'm very glad they've changed their name. So the suits are available for purchase. You can buy different types of suits. We have the standard one, but you can get custom ones made. They're quite expensive. They're around $2,000 to $2,500 per suit. However, if you do have a training program and you will get good use of them, I highly recommend them. We tested them with our patients with bariatric care needs to make sure that they were feeling okay about us using the simulation suits, and we got full endorsement that this was an excellent way of training. I have a grad student right now who is doing a study, a 3D gait analysis and mobility study, to see how much the suits actually simulate movement, because we know they improve empathy and understanding, but we don't know if they actually truly replicate the movement of somebody with maybe severe obesity. So stay tuned for that, and we'll let you know about those results.
So with respect to your program and transitioning people out of the hospital back into their homes, aside from the potential for the community sector to come in and get training on how to work with the bariatric patient, is there anything else you do to help that person transition safely back into their home so they don't readmit into hospital vis-a-vis equipment?
Yeah. Yeah, it's a great question. I'm going to say something, and I don't work for Alberta Health Services, so I'll put that into context. Kathy may not be able to comment so much on this, but I'll leave that to her. Up until the end of March, Alberta Health Services had a phenomenal resource called the Provincial Bariatric Resource Team. And that resource team had a nurse, a physiotherapist, an occupational therapist, and a dietitian, I believe, and a psychologist. And this was a team that anybody in Alberta Health Services, and I think even outside of Alberta Health Services, was using it. And they could ask questions about equipment or training or education. And this consulting group would go and help solve problems around things like transitioning patients from hospital to home, or to long-term care, or advocating for equipment, or actually running some of the weight bias and sensitivity training. They actually were very much a part of developing some of the videos that we are going to be sharing with you. The issue is that hospitals make tough decisions around fiscal needs. This group was disbanded, but what we're finding now is that's left a real gap in where do people go. And so that increased the demand on the Diabetes, Obesity, and Nutrition Strategic Clinical Network. And so they do now have somebody almost full-time, I believe, that is helping to try to fill this gap. But what we're finding is that we need to find a new way of providing these kinds of services so that we can create efficiencies. And what we're feeling is that these guidelines are going to help with that. And the funding that we're trying to go for, that we're pitching for tomorrow, is to take these guidelines and transition them so we can provide the same amount of care and training in the home environment and also the supported living environment.
And that's wonderful to hear, because without that replication, you know, people just get readmitted because they don't have the support in the home. And the fact that they can be trained at your facility is fantastic. And then it's a matter of making sure that the home environment can accommodate what is needed. So that's
Absolutely.
great, and great information for us to take to our own funders. A couple of other quick questions. Do you have any sense of the percentage of Alberta Health staff that completed the Move Safe program? Was it mandatory?
Well, yes, it is mandatory. So the It's Your Move training is mandatory for all staff that are responsible, that would be moving patients or doing any transfers with patients. And at the University of Alberta, all of our occupational therapy and physical therapy students have to have that training and be certified before they go out on clinical field work. So we're hoping that they're also instilling that culture when they go in. The thing is that the bariatric training videos have only been available for about a year, and just over a year actually. So they were not part of the standard training program, but we are getting buy-in from that program that they will be part of the standard It's Your Move training program. So that eventually, we are hoping very soon that will all be mandated as part of the overall patient lifts and transfers patient handling program.
Thank you very much. And two last questions. Were there injury rates that you're aware of specific to the bariatric population, so bariatric injuries, that helped to move this forward?
Yeah, it's Kathy speaking, and unfortunately, when we have an injury in Alberta Health Services, it goes into My Safety Net system where it's recorded, and there is no correlation or weight is not mentioned. So the strategy we've come up with to help identify when an injury happens is to have the debrief survey after the injury has happened to see if we can, you know, again, look for gaps. Was it lack of equipment, lack of access to equipment, not knowing how to use the equipment, etc. And did the patient have bariatric care needs, to see if we can correlate that. So right now we don't have baseline, but we will look at going forward and seeing if we decrease the overall disabling injury rates with our implementation of the standards, and do more, as I mentioned, investigation after an injury has happened to see if we can identify any mitigating actions that we could do to prevent future injuries.
Wonderful. We will ask you, if you can, to share the reference for the Belief and Attitude Survey. And the last question we have time for today is, do you have a standard for how many of the bariatric suites, you know, the difference between that suite and the regular suites?
Yeah. Yeah, the difference, if I'm interpreting the question right, is that the difference is usually it's a bit of a larger room. It definitely has a ceiling lift that would have a weight capacity usually of 1,000 pounds, and that's just because it may not be the patient that weighs 1,000 pounds, but by the time you get everything involved in there and some staff pulling on it, the bed is a bariatric care bed, which is larger, and so definitely it would be taking up a private patient room, but it also thinks about the bathroom. And is the bathroom bariatric friendly? Meaning, is the toilet able to support a weight capacity of over 700 pounds? Is it floor mounted? What is the depth and size of the actual seat and bowl? Is there a shower that's accessible? It's looking at all those pieces of equipment all working together, because oftentimes we'll have bits and pieces bought independently, and then when you try to work with them together, such as like a portable lift will not fit under some of the bariatric care beds because of the motor of the bed. So that's the difference, really, is how everything is integrated and works. And really the significant difference is the weight capacity of everything in that room, the mechanics in that room, and the size of the room.
Wonderful. Well, thank you very, very much. We're unfortunately at the end of our time. I knew this was going to be a really, really popular topic and lots of questions. And we will be very interested in hearing, you know, 9 months down the road, how the implementation is going, what short-term outcomes you're seeing, and I expect we will have a follow-up webinar with you. So thank you very much, and we look forward to the evaluation from our participants today.
Great. Thank you for having us.
Yes, thank you very much.